Hello, everyone. My name is Radwa. I did my flashcard presentation this week on the hydration. So to start off with the disease process, dehydration is defined as a physiological disturbance within the body that is caused by the reduction or translocation of body fluids. This generalized definition is used more colloquially to mean a deficit in the body fluid of any kind, as opposed to a physiological definition. In clinical practice, dehydration refers to the loss of body water, whether it'll be through the GI tract, renal, or insensible loss. Wet or without salt, at much greater rate than the body can replace. Dehydration can also result from a shift of fluids, as seen with ascites or effusions. Capillary leakage of body fluids can also cause an increase in output, leading to hypovolemia, such as with sepsis. Clinically, to provide a precise and appropriate treatment, the provider must distinguish the cause of dehydration. Dehydration can result from plasma volume deficit, salt and water depletion, or simply just water depletion. In the presence of an infection or being in a very hot environmental temperature for a prolonged duration of time will lead to a greater water loss in comparison to electrolyte loss. This type of dehydration is called hypotonic dehydration, and it is the most common in such scenario. Vomiting and diarrhea are the two most common signs and symptoms associated with the diagnosis of isotonic dehydration. There's an equal water and electrolyte loss with this type of dehydration. Infants and children are the most vulnerable group to be diagnosed with isotonic dehydration, as they are more susceptible to experiencing severe vomiting and diarrhea. Lastly, the use of diuretics can cause hypotonic dehydration. Hypotonic dehydration is distinguished by having greater sodium an electrolyte less than the loss of the water. This type of dehydration is most commonly seen in an elderly population. For this particular type of dehydration, it is significant to carefully monitor the level of sodium. The normal level of sodium is between 135 to 145. To accurately analyze one's condition in order to achieve a diagnosis, a thorough appraisal of the patient is needed. Their baseline weight, the clinical assessment, laboratory testing, and the gathered knowledge of the patient's history. A good indication of assessing the severity of dehydration is to accurately measure one's body weight. A total weight loss of 2% from the patient's baseline weight is considered, mild dehydration. A weight loss of 5% indicates a moderate level of dehydration, while an 8% of total weight loss is indicative of severe dehydration. Moving on to pathophysiology, 70% of the human's body mass is water under normal physiological conditions, that is. 2/3 of that body fluid is cellular, while the remaining 1/3 of the fluid is extracellular. 75% of the extracellular fluid is interstitial, while 25% is extracellular fluid is intravascular. The extracellular compartment is the first in line to be affected during the early stages of dehydration or fluid deficit. The water loss during early stage contains electrolytes compositions including sodium that are similar to plasma. The loss of water and electrolyte causes a shift of the fluid, resulting in reduction of the circulating blood volume. This reduction of volume is a result of hypovolemia that accompanies dehydration. Consequently, if the fluid loss is uncompromised, it will affect the stroke volume that will lead to a fall in the cardiac filling pressure. This will ultimately lead to a decreased cardiac output In an attempt for the body to compensate, it will orchestrate different homeostatic responses within the body to restore normal volemia. In the body's attempt to combat this change, the body activates the ROS system, suppression of AMP, while stimulating AGH release. The body also stimulates the nervous system. Those measures lead to renal conservations of water as well as salt. The changes within the body due to the dehydration directly affects the kidneys. The decrease in volume will lead to an increase in the level of serum osmolarity, as well as the activation of vasopressin. As a result, the patient will have concentrated urine. To compensate for the water depletion, fluids will shift from the extravascular space to the intravascular space. This shift will also cause change in the concentration of electrolytes and water levels in different compartments within the body. This shift in electrolytes and fluids will be reflected in the patient's lab results. For risk factors, there are multiple risk factors that are associated with dehydration, including urinary incontinence or polyuria, infections, high fevers, vomiting, diarrhea, use of steroids, diuretics, laxative, polypharmaceutical use with the elderly population, obesity with a BMI greater than 27 or a BMI lower than 21 are also at risk. A history of stroke, dementia, or patients who suffer from a disease of a decrease in functional dependence, whether it's due to a decreased level of consciousness, impaired mobility, dementia, or residual stroke deficits that are also can increase the risk of dehydration. Additionally, dehydration is a potential threat to people with chronic illnesses such as uncontrollable diabetes and kidney-associated diseases, and dysphagic patients who are receiving only high-protein internal feedings. Anyone can become dehydrated, but infants, children, and the elderly population are at a greater risk with life-threatening consequences. Those groups have a higher susceptibility to develop dehydration due to their inability to quickly conserve fluids. They also do not have the capability of maintaining gluten fluid reserves. A specific risk factor with the elderly individuals is their decreased level of staying well hydrated and their increased loss of fluids. Meanwhile, children and infants develop dehydration due to a higher surface area to their volume area. Major signs and symptoms of dehydration. Clinically, dehydration has poor sensitivity and specificity due to its unspecified signs and symptoms. Therefore, the provider must have a high index of suspicion in order to diagnose the patient with dehydration. Symptoms of dehydration can vary from mild to severe. Mild to moderate symptoms of dehydration are generally presented as thirst, identified orthostasis, tachycardia, decreased urinary output, dry oral mucosa, decreased skin elasticity, and skin turgor, especially in subclavian and the forearm areas. However, with the elderly population, relying on skin turgor as one of the symptoms of dehydration is not reliable due to the loss of their subcutaneous tissues. Infants will have a depressed soft spot on their skull and they'll have a decreased number of wet diapers. A quantifiable sign of dehydration is calculating a 2% to 5% decrease from one's original weight alongside of analyzing lab results such as hyperosmolarity and elevated plasma sodium level. Clinical signs of severe dehydration in an individual present as lethargy, cognitive impairment, including confusion or delirium, remarkably concentrated urine output, amber in color with a strong odor, cellular disruptions, further function decline, falls, rapid weight loss, or 8% decrease in bodily weight. renal failure, and possibly medication toxicity. Diagnostic testing. Changes in the water concentration along with the electrolyte shifts in various compartments with the body are due to the fluid shift between the extracellular and intracellular components. This change is reflected in the results of patients' blood tests. Therefore, to help confirm and pinpoint a diagnosis of dehydration, a set of blood tests and urinalysis are ordered. Tested for the level of total serum protein and the level of hematocrit gives the provider a rough estimate of a possible reduction of the circulatory blood volume. A provider will also test for potential metabolic acidosis by measuring the level of pH as well as the CO2. In the post-acidotic phase, it is highly important to test for the level of serum potassium in order to diagnose any overseen renal or adrenal insufficiency. Since dehydration can be a result of many other diagnoses, one should rule out diabetes by testing for blood glucose, even in the absence of a suggestive medical history. Measuring the level of sodium helps estimate the osmolarity of one's body fluids. To analyze urinalysis results, a patient with dehydration lab results will ultimately have raised serum or urine osmolarity that is greater than 295. Raised urine specific gravity, which is greater than 1.020, increased urea to creatinine ratio with a BUN creatinine ratio that is greater than 20. Results may also show a reduced estimate GFR that is less than 60. In a dehydrated patient, hemoglobin and hematocrit may appear higher than normal. This is due to decreased volume. The serum protein level will be increased to be greater than 5. The most significant lab abnormality is sodium imbalance, which should be carefully monitored, especially within the elderly population. The sodium level will be abnormally high over 145. Increased level of sodium can affect the brain cells, leading to potential seizures, coma, or brain hemorrhage. Although all of the above measures are good markers to clinically help provide with diagnosing dehydration, the amount of deficits that has occurred can be best estimated by an actual weight. This concludes my presentations on dehydrations. If you guys have any questions, please send me in the comment section. Thank you so much.